I think now we are to have some discussions about the topics that we had today. So apart from our speakers today, we also have a guest in this program, Dr. Bulent from Turkey. And hello, Dr. Bulent.
Hello. Hello.
Hi.
For everything.
Thank you. Thank you for joining us. So, okay, can you please discuss some of the ideas or some of the results that has been involved in the topics today among them yourselves? Because for now we don't have very many questions in the audience.
Yes. I have experience with lung ablation more, and we use in my hospital before in lung ablation, radiofrequency ablation. Now we use microablation. The difference between RFA and microwave is in lung ablation, we see less hemorrhage and less pain. And your criteria is 3 centimeters mass. About 3 centimeters, we don't ablate the mass mostly in lung. And this is mine. But for me, it was very interesting for the immune response, what the last speaker speak. Can the last speaker explain, can we transfer this knowledge to thyroid ablation? If we do thyroid ablation, which marker can we use in the clinical routine for evaluate or measure the immune response in the patients?
Dr. Joe is specialized in breast treatment, but I don't know if he's had any experience with thyroid ablation. Dr. Joe, could you please explain it for us?
Me?
Yes.
Yes.
Can I make a comment on that for thyroid ablation?
Yes.
We all know that the market for thyroid ablation started with alcohol or forms of sclerotherapy, followed by laser, and then followed by radiofrequency ablation. In the beginning of microwave, we started using the original microwave antennas with the 2 centimeter active tip, the long ones. They were working, but we had reports of increased complications. All this changed when all vendors started providing us microwave antennas specifically designed for the thyroid. The shorter ones, like 10 centimeters in length, the thinner ones, 17 or 18 G in diameter, and most importantly, the ones with a smaller active tip.
Yes.
These smaller active tips are a game changer, and they actually introduced microablation as a safe and efficacious technique for benign and malignant thyroid nodules or for recurrences after surgical operation of thyroid cancer. And I think that nowadays, microwave for thyroid ablation, but also for any other location, is a well-established percutaneous ablative techniques.
Yes.
Thank you, Dr. Felpiades. Thank you very much. Actually, I have a question for Dr. Chen. He mentioned that he used the trocar needle for ablation of DGOs. He does microablation as well as biopsy at the same procedure. So I was wondering, is it always ablation after the biopsy, or it's the other way around? What is the difference, if you could explain?
Because the most cases we done ablation is GGO. It's the small nodules in lung. We know that there is a lot nerve vessels among the GGO. So when we cut, there might be more chance to bleeding. So if the nodules is cut by the biopsy gun first, there might be disturbance to our target. So now we do some pre-operations procedure. This is mean we do the ablation with lower bars and short times to make the vessels to clot. We will lower the risk to bleeding and first, and then we make the biopsy followed by the 1 or 2 minutes ablation first. So the tissues might seem can be identified by the pathological to be a good tissue.
Okay.
So we usually do this one for a few cases. Some cases might identify the tissue is fresh from the pathologists.
Okay, I have a questions to Dr. Zhu. How have he any experience with breast fibroadenoma microablation, and what is the results?
Hello, Dr. Zhou. Yeah.
Thank you very much. As in our own experience, the fibroadenoma microablation for treatment of fibroadenoma is very effective, and the ablation rule we think is smaller than for breast cancer. And about for example, when we treat the breast cancer, about the diameter was 2 centimeters, and we use microablation for the treatment about 2 to 3 minutes, and for the fibroadenoma, I think 1.5 minutes may be enough. In our published papers, we can see we explained this difference in our published papers published in International Journal of Hyperthermia. You can see in our paper. Thank you very much.
And how is the shrinkage rate in fibroadenomas approximately with microablation? What is your experience about this?
小店他这句话我没懂。
就是做那个 fibroadenoma 的时候，它的那个吸收率大概多少？微波消融的情况。
Okay. For smaller lesions, the 吸收率怎么讲呢
Shrinkage.
For smaller lesions, the shrinkage rate was very high. When smaller than 2 centimeters with the diameter, the shrinkage rate was about, I think, was about 15 to 100% after 1 year. But for larger lesions, and this rate was very low. For 2 years, most of the cases we can see the lesion and ultrasound is still observed in ultrasound.
And I have another question. In breast fibroadenoma microablation, which antenna do you use? The antennas that we use for thyroid ablation, small active tip, or bigger antennas? Which antenna do you use in breast fibroadenoma ablation?
In my opinion, many types of this antenna can use, but in our center, only one antenna was used. The standard, 小弟，我们用的那个标准的 standard 是多少毫的
I think that was 16 gauge 3.5 millimeter active tip antenna.
Yeah.
What I would like to add about breast fibroadenomas is the follow-up imaging. You should advocate the patient to wait for the follow-up imaging. If you do the MRI on the first month, you see a lot of inflammation. It's a mess over there, and the image is actually really nasty. You should wait for a minimum of 3 months before you perform the MRI after ablation of fibroadenomas. You will have a very good visibility of the ablation zone then when the inflammation will subside.
Yes.
Interesting.
Can I make a comment about the lung ablation for microwave? I think microwave is offering us a game changer in lung ablation. We know that we can use it for lung cancer, for pulmonary metastasis. We have seen an excellent talk about a new indication about the ground glass opacities, and we also have nowadays indications of the other extremity. There are studies in the literature concluding that when you compare microwave ablation with SBRT for advanced inoperable patients, the survival benefit on terms of survival rate is exactly the same. And microwave ablation, interesting enough, was performed in patients with higher morbidity and more comorbidities. So I think it's a great tool, not only for preliminary stages of lung cancer, not only for oligometastatic disease in lungs, but also for advanced cases where surgical operation cannot be performed. And if I may add, we can propose microwave ablation depending on local expertise, even for cases of hemoptysis or in patients who are suffering from pain due to infiltration of thoracic wall. And microwave can offer significant reduction as a palliative treatment in these patients as well. I think that Dr. Chen showed a great case. It was the one with the pneumothorax. And if I may speak on behalf of all of the presenters here, it's a request from the physicians to the vendors. We need stick mode for microwave ablation in the lung. You have pneumothorax, you don't have such a solid parenchyma. Microwave antennas are moving inwards or outwards. You need to have a stick mode. That will make our life easier in pulmonary ablation and will increase our safety and efficacy rate. At least this is what I'm thinking about thermal ablation in the lungs.
But I think the most difficult is the pathological finding by biopsy. Is because it's quite difficult to do so, especially in small GGO.
Actually, it makes sense. It's very difficult to target the lesion.
Yeah.
Even in most of the cases, I guess that you park your microwave antenna right next to the lesion. This is very small, and you can take advantage of the larger ablation zone that you can use to cover the whole lesion.
Yes.
Can I ask something from technical point of view? Do we all agree on whether to perform track ablation on lung lesions or not? I don't know which is your practice. Do you perform track ablation on pulmonary lesions or not?
他是说胸部有黏连的时候用吗？
真到消融。
哦。We do. Because after the ablation, usually do the ablation through the needle. 针到消融，他是说做完消融之后针到消融吗？还是说？
对，就是针对肺消融这一块儿，是不是大家都做针到消融，还是说大家可能会有不同的操作方式？因为
基本都做。刚才说的针到消融是用同轴针消融，是这个意思吗？还是说只是说消融它退出来的这个针道？消
融退出来的针道。
那这常规的。
就是都做的。
It's routine.
Okay.
Great. Bulent, do you routinely do track ablation?
Yes, we do. Yeah. Doctor,
I mean for lung lesions.
Yes. I have a question for you, Doctor.
Before the question, I have to admit I'm not doing it. I'm afraid of bronchopleural fistula. It's the only location that I do not do track ablation. I do the microwave ablation, try to have adequate margins, but I avoid track ablation. But that's my own personal practice. Tell me.
Yeah, Mr. Dimitri, I know that you have a very big knowledge about bone metastasis treatments. And I have a question. If we have a lytic bone metastasis from breast or another, or from lung, after ablation, do you perform cementoplasty in these cases or only microwave ablation in lytic lesion?
Yeah, that's a great question. I would say that it depends on the lesion in terms of location and size. If you have a lesion located in the thoracic wall, you can easily perform ablation and that's it. If you have a lesion in the peripheral skeleton, depending on the location, I would combine microwave ablation either with only cement injection or with percutaneous screws, depending on the location. Cement is a great material for the spine. It's a great material for axial bones, where you do not have rotational or torsion forces. In long bones, in specific locations in the peripheral skeleton, for example, in the femur or in the pelvis, you have different forces other than the axial ones. So you need something better than cement. And I think that nowadays we do have the evidence that combining ablation with cannulated screws and cement injection is the ideal combination for these patients, for these lesions. But in all cases, this is an area that you need to have a lesion-tailored approach. You see if you have a break on the bone cortex, how large is the break? Do you have a lytic lesion? And you proceed with the treatment. The great advantage of microwave in bone ablation is that you can easily treat blastic lesions as well. This is something that we are not able to do with radiofrequency ablation. Nowadays, with microwave, we can perform ablation on both, actually on all, lytic, mixed, and blastic lesions. And it's a great advantage for these patients.
Yes, thank you.
Thank you very much. I have a question, I got a question from the audience. So it's about lung ablation. They're asking, is CBCT, ablation under CBCT is similar with under CT guidance? Is there any difference between CBCT and CT guided microwave ablation?
On non-tissue, on non-nodules.
Okay, can you please explain a little bit more, please? Because I think we have someone online listening to this part.
I try to answer this question by myself.
Okay.
Actually, under the CBCT, you can find more space to put inside your antenna because there is no limitation by the cone of the CT. When do CBCT, you can use the 3D with control imaging immediately after the CT scan, so you can adjust the antenna more quickly than under the CT. But according to my experience, if you do a small lesion, just like a small GGO, the CBCT's imaging is unlikely like so well. It's not good as the CT. So might be some trouble for you to find the target. But if the target nodule is solid tumor, it may be no difference. And the evaluation of the final ablation's results might be better than normal CT. Is my own experience.
Okay,
thank you very much.
Can I say something on that? Obviously you can use cone beam CT. I mean, you have the software and you can use it for lung ablation. Obviously, the more solid the lesion, the better it is for cone beam CT. I have to say though that in my eyes, if you're going to take the radiation exposure both for the operator and the patient, there is nothing that can compete with CT fluoroscopy. And with the technical, if you pay attention to the technical parameters, you can have an equal amount of radiation burden, both for you and the patient. And CT fluoro is great. I mean, you can have 3 images cranial, 3 images caudal of the lesion. You can easily stick the microwave antenna inside the lesion under CT fluoro. It's like playing a video game. It's really great.
Thank you very much. Thank you very much. Okay, so there's another question about something we did not discuss today. There's a question from Dr. Laila about thyroid. I would like to make a question about the follow-up of microablation on microcarcinoma. How are they doing it? Doing FNA? If you don't mind, could you please explain a little bit about the microablation of PTMCs?
Bulent, do you want to take it over and start?
Yes. In microablation of papillary microcarcinoma, it is very important the location of papillary microcarcinoma, because we only don't ablated the papillary microcarcinoma, we ablated 2 millimeter thyroid parenchyma surround the papillary microcarcinoma. Therefore, it must be located in the central part of the thyroid parenchyma. In subcapsular location or outside the extra growing nodules is not suitable for ablation. This is the one rule. Second is the reference measurement must be after ablation, not before ablation. While we ablated the 2 millimeters surround the thyroid gland, we ablated a more big area. And this is the first reference diameter measurement. And after 1, 2, and 6 months, we only follow up with ultrasound examination. But as we know, 15 and 20% of the thyroid papillary microcarcinomas are multicentric. There are some have millimetric focuses that we cannot see at the ultrasound. Therefore, it is very important the first 2 years follow-up after papillary microcarcinoma to detect extra focuses. Otherwise, it is the same follow-up with the thyroid nodules. But my experience is what I see in papillary microcarcinoma follow-up, the volume reduction rate, the shrinkage rate is more higher than the normal nodules. I don't know why. Sometimes after 6 months or after 1 year, we don't see the lesion. It is totally resolved. We don't see this in thyroid, benign thyroid nodules, but we see this sometimes in papillary microcarcinoma. And the second important thing, before papillary microcarcinoma, we must look to the variant of papillary microcarcinoma. We can only ablate the classical variant, but we have some aggressive variants of papillary microcarcinoma, Thaler variant or oncocytic variant. This variant is not suitable for ablation. Or we can some molecular patterns looking, but normally in clinic routine we don't look. Only we must looking to the variant of papillary microcarcinoma. We cannot ablate the Thaler variant, the oncocytic variant, only the classical variant. Second important thing is we must have around the papillary microcarcinoma a 2 millimeter heel T thyroid parenchyma while we ablated it. Thank you.
Bulent, just echoing the queries that arise from this question, do you think in the follow-up period of this patient, there is a position and a place, first for FNA of the ablated lesion or of the surroundings, and second, of using contrasting phased ultrasound in order to verify total necrosis of the lesion?
Yes, in my country we have no contrast enhancement material, therefore we cannot use it. Second, we have My wife is a pathologist, therefore sometimes I do experimental things. Sometimes I take after 3 months a true cut biopsy. After this, we only see in these cases acellular hyalinizations. We don't see any viable structures in these cases. And in ablation of papillary microcarcinoma is different than benign thyroid node. We don't use the moving shot technique. We go only with the needle centrum of the microcarcinoma. Most of them is under 1 centimeters, and we wait there that it covers around 2 millimeters. And after ablation, after 5 minutes, if the bubbles resolve, we see a very sharp line around the focus. I can only do this while I don't have an enhanced ultrasound in my country.
Great. But I guess we all agree that laboratory workout, like TG values and everything, they are not helpful in the follow-up period.
Yes, why? Because thyroglobulin are produced by all of the thyroid parenchyma, but it stayed there, therefore we cannot distinguish it. Only ultrasound follow-up, maybe after 6 months or 1 year that the patients feel it better, we can take a true cut biopsy of this point, maybe, but I don't do it.
Great.
I have another question for Dr. Chen. Actually, this is the follow-up of my last question, the biopsy and microwave. First microwave ablation, then biopsy with the trocar. So if you do the ablation for hemoptysis before biopsy, will it affect the biopsy results?
Yeah. If the parameter is very high, it must be some you mean 就是焦掉了，就是 tissue is it may be a disturbance by the final pathological findings. So we always to adjust the parameter before biopsy. 现在我们now we use the 40 bars for 1 to 2 minutes to just in order to hemolyze the vessels but not change the tissue's structure.
Okay, thank you very much. Is there any discussions to?
Can I ask regarding the immune response? Do we have any data suggesting superiority of one ablation technique over the other regarding the impact on immune response? Do we feel that microwave works better or works on a lower basis regarding the impact on immune response? My feeling is that for sure it works better than radiofrequency ablation, and we do have the data for that, and most probably it seems comparable to other thermal and non-thermal techniques.
I think it's a question for Dr. Zhou.
A very good question. And now I will revise my one paper about radiofrequency ablation compared with microablation in the treatment of breast cancer, and we compared the immune response of these two techniques. In our paper, we find that microablation can induce strong cytotoxic functions of T cells than radiofrequency ablation. And radiofrequency ablation in the treatment of breast cancer can induce the enhanced levels of percentage of CD8 positive breast cancer, of CD8 positive T cells, but the function of the cytotoxic function of these CD8 positive T cells was not strong. So I will submit this. I will submit this paper in the future. We found that micro may and this is and our data was similar to the published paper about compared with cryoablation compared with radiofrequency ablation. Radiofrequency ablation can only evaluate the percentage of CD8 positive T cells, but the function of CD4 was not strong. So in our published papers about microablation, all the CD4 positive T cells was very high, and the immune response was still high. So in our data, I think microablation is a treatment of breast cancer. The immune response is strong than radiofrequency ablation. That's my opinion. Thank you.
Dr. Joe, just being the devil's advocate here, regarding ablation of breast cancer, there is a lot of discussion about the sentinel lymph nodes, the guard lymph nodes. Do you think that it is an issue for ablation of breast cancer? We should perform biopsy to these sentinel lymph nodes. We should propose ablation of these lymph nodes. What do you think is the controversy regarding this issue?
这里他说淋巴结要不要做，对吧？还是免疫啊？
淋巴结要不要做的问题。
In our breast surgery, sentinel lymph node biopsy is necessary for the treatment of early stage breast cancer with clinical negative axilla. So when we apply ablation treatment for the breast cancer, and I think sentinel lymph node biopsy is also needed for the treatment of this treatment. But in the future, in some clinical trial, pretend to omit the sentinel lymph node biopsy for some patients. I think in the future, for early stage breast cancer, only ablation of the breast cancer is necessary and can omit the sentinel lymph node biopsy in the future.
Thank you. In the lung, we do have percutaneous approaches and they work really great. I totally agree with all of you. But one thing that is coming really hard on us in the near future is endobronchial microwave ablation. And that is a field that we, as interventional radiologists or everybody who is applying percutaneous approach, will play a specific and very important role, simply because no matter where they can reach with a bronchoscope, by using cone beam CT, we can actually identify the exact and correct location, even of the endobronchial microwave probe.
Dr. Fabianos, have you tried lung ablation with the cone beam CT?
Actually, I have a very limited experience. I have done 1 or 2 cases just to try it. I'm a CT guy. I prefer CT fluoroscopy. I feel that it makes my life easier, specifically for these lesions, which are really movable in the lung with the breathing of the patient. If you even have an anesthesiologist present and you can have jet ventilation, that's really great. The lesion stands still and it's a sitting target. Even if you don't have jet ventilation, I have the feeling that with CT fluoro or even with standard CT, it's a great modality for accessing these lesions. But I'm hearing what other people are saying, and I think at the end of the day, it comes to local expertise. If you do it under cone beam CT, it's great. If you do it under CT, it's also great. At the end of the day, you want margins. That's it. I don't care how you do your ablation. Do it correctly. Have as an end result an A0 ablation, with adequate margins. And specifically for the lung, as Dr. Chen showed in a great example, we have to wait 1 or 2 hours in order to see the surrounding ground glass opacity of the ablation zone. If you have a CT scan immediately, it's not the real one. You have to wait for a couple of hours at least, and then you see that this is your real ablation zone.
No, I agree. I have a question for Dr. Felipe. Do you do some ablation on non-modules smaller than 1 centimeter?
Yeah, we absolutely do. Actually, nowadays, most of our pulmonary metastatic lesions, they range between 0.5 to 1 plus centimeter. The oncologists are referring these lesions very early in the course to us, and we perform ablation. As I said before, sometimes it's tricky and very difficult to puncture the lesion itself. If you have a 0.8 centimeter lesion, it's very difficult to puncture it with the active tip of the antenna. So the effort there is to park the active tip of the antenna right next to the lesion and perform the ablation, covering the lesion with adequate safety margins.
So do you always do the biopsy?
Actually, we do not do always biopsy because these patients are cancer patients. They have a known cancer disease, and they present in the course of the disease with a new lesion. If the biopsy is necessary, I would, like your example, use a coaxial system, do the biopsy, followed by the ablation. And just trying to provide some more excuses for what I have asked earlier from the vendors. Imagine to have a microwave antenna with a stick mode. You place the microwave antenna, you do the stick mode so the antenna remains in position, you insert your biopsy needle, sample the lesion, pull away the biopsy needle, and start your ablation. It makes your life heavenly, beautiful.
Thank you.
Thank you very much. Dr. Chen, I have another question for you from our audience. So is biopsy and ablation performed simultaneously or in two different sessions? In what kind of situation it should be done simultaneously?
I think if the pathological finding is quite important to the treatment of the patient, we might do this one. For example, if it's a metastasis tumor, maybe we do not do, or some we said on some multiple primary lung cancer, there is some high risk GGO, smaller than 8 millimeter. We do not do biopsy. We just judge the risk of the nodules by the CT details to see is in consolidation, target ratio is less than 0.225. Is more likely to be a pre-invasive lesion. So local treatment is good enough for them. But if the solid tumor, might we do the biopsy at the same time?
Thank you very much. Thank you very much. So that is pretty much all the questions from audience. Do you have any more questions? Okay. So I think the discussion part went even more attractive than the presentation part, but well, we had very nice presentations as well. But I can see that our audience enjoyed the discussion part more. So thank you very much for all of you for everything and the great discussions today, the interesting points that's been brought up. I think that's very helpful and very informative. I hope that we will have another chance in the future to discuss even more and some new topics as well. So I guess that's it for today's topic, for today's program. Thank you very much all for your efforts.
Thank you. Have a great evening.
Thank you.
Thank you. Bye.
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 Thank you, Dr. Bulent. Thank you, Dr. Chen, Dr. Joe.
Thank you.
Bye.